The committee will come to order, and the next senator for her questions is Senator Cantwell.
Thank you, Mr. Chairman. Thank you, Secretary Kennedy. Thank you for your very long statement that's in the book. You covered a lot. I think it was 10 or 11 pages. I don't think secretaries usually show up covering 11 pages of material in their written testimony. So I wanted to ask a couple. I have three subjects that I want to go over if I could. One, no. Ernie Moniz once said, I read the 4-year quadrennial energy report for our nation, and he thought that was crazy. But, you know, when somebody spends that, I think he probably took him 2 years to write what was our 4-year energy outlook, somebody needs to read it. So I actually think you covered a lot of subjects there. So I wanted to ask about that because I have priorities that I wanted to cover and see if we could get your commitments on them. One, you talked a lot about Indian healthcare, which I appreciated. I've met with several of my tribes. One issue is that we don't have for urban, you know, IHS does their thing, you've addressed trying to fix that, but Indian urban health needs the full FMAP funding. We got a fix, myself and Senator Murkowski, but it only lasted for 2 years. And so we would like to see urban Indian health get the full federal medical assistance for the Indian healthcare programs, and would you work with us on that?
Absolutely and enthusiastically.
Okay, great. Second
and
issue.
You can call me directly on that. And
great. So appreciate that. This is a really big issue. People don't understand, but we have 150,000 American Indians and Alaska Natives that live in urban areas like Seattle. And so when they only get half the money for the care that everybody else gets, it creates a disparity in actually being able to deliver that care. Okay. Second issue is in the cuts to Head Start, in the cuts to the administrative issues in Head Starts, and not putting out the new RFP for proposals. Walla Walla, which is, yes, a real place, has, they may have to shut down their whole Head Start program. So are you going to put out requests for proposals for funding for Head Start?
A request for proposal for, I mean, Head Start,
there's been some administrative cuts, and so one of the things they haven't put out are these RFPs that allow programs in small communities to actually apply for those federal dollars and then be able to keep their program open. I think what I should do is send you a letter on this.
I mean, you know, I'm very committed to Head Start. My family started Head Start. We protected it in the budget. I just put $62 million extra into it so that they can do good nutrition. I'm happy to work with you to make sure.
I think this is an area where we might say, yes, Secretary, would you call the administrator in Walla Walla, Washington? Okay, so the big question.
I'm happy to do that.
Thank you. The big question I wanted to ask about is this issue of WISER. I don't know if you've heard about this, and you mentioned briefly in your testimony the coverage of modernization of CMS in technology. And the concern that I wanted to try to address today is something that's been raised in our newspaper in Seattle. We obviously know a lot about AI because we have a big AI community, but what's happening is AI is being used as a denial device for the CMS system, and it's apparently had some problems where it's not taking a few days to find out whether you're going to get covered or not. It's basically taking weeks to find out that you're denied on things that never were a prior denial before. And so what I'm worried, this is a gentleman who had some back issues and wanted to get what would have been under Medicare, an approved system by his doctor, whether he could have that steroid or whatever care he could get. Now he's under this WISER application process, which can just turn down and deny. So we have hospitals calling me about this. I have doctors calling me about this. I have patients calling me about this. So I appreciate if you take a look at it. Yeah, go ahead.
Okay, first of all, that kind of delay is unacceptable, and we will work with you on it. The WISER model, you know, we do only 5% prior authorization across Medicare and Medicaid. But we found we were being ripped off by certain categories of procedures that are not good for the patient, and a lot of time they're unnecessary and they're very lucrative for the doctors. Skin substitutes went in 3 years from being 250 million to 23 billion. The spinal surgery, certain kind of spinal surgeries, which is maybe the one he's in, and then knee arthroscopic surgeries. So the AI targets those, and I don't know what happens then. But anyway, it shouldn't be delayed, and we will try to work with you to
I just want to bring
fix
in
it.
my last point, because I know my time's expired, but this is exactly the point. Somebody might have had a bright idea. I think AI should be used for advancing research and finding things that might take us years to figure out and find them out in months instead. But to use AI as an app or a tool that might deny people and then cut them off of Medicare, when this part of Medicare was never a referral, is making me anxious that somebody really does think that AI should be used to judge our Medicare services. And so it makes me anxious, so I appreciate you saying you...
It's supposed to allow us to detect fraud early. There's probably kinks in the system. I will work with you to try to straighten that out. But as I said, we were getting ripped off for $23 billion just by one category of procedure.
I don't want Mr. Magnuson, who I showed, to be ripped off, though. And I think that's the scary thing about AI is that if we really think we're going to put AI in charge of deciding on instead of doctors, I think we're going to have some real problems. And also, would you think about the transparency on this? Because if you created that model or that app, or I think here is a third party, what is the transparency that we all have about how that app works?
Yeah, it's supposed to have a human supervisor so that the human, when prior authorization is denied, that there's supposed to be a human being who checks that off, and that the AI just identifies at the outset.
Well, we want to know before so that we're not, I hear what you're saying. So thank you, Mr. Chairman.
Senator Barrasso.
Thank you, Mr. Chairman. Mr. Secretary, thanks for being here today. I really applaud what the administration's doing in terms of focusing on making America healthy again. And we can agree that addressing chronic diseases is not a simple task. At its core, making America healthy depends on prevention. I believe that as a doctor, practiced a long time, was involved with the Wyoming Health Fairs, all focused on prevention. There is something called the U.S. Preventative Services Task Force. It has a 40-year history of providing independent, evidence-based recommendations on preventive care. It's part of HHS. And as a doctor, I've relied on these recommendations over the years. They've helped shape the standard of care across the country, from cancer screening to heart health. And I believe if more people followed the recommendations, our country would be a lot healthier. Last week, before the House Ways and Means Committee, you said you thought the task force had been lackadaisical and negligent for 20 years. I mean, they did a lot of good work on breast cancer prevention, cervical cancer, alcohol in pregnancy, and then you said you'd plan to bring on new members with a clear mission. So over the last year, they've canceled and not rescheduled multiple meetings of the task force. The department has. One of them was just on 3 days' notice. And I'm concerned that these actions show that we're not really prioritizing this important task force. So how are you demonstrating that you have a serious and consistent plan to reform the task force on prevention? And what exactly do you believe the Preventive Services Task Force has been getting wrong?
The task force is critically important. It plays a critical role in getting compensation, CMS compensation for important approved interventions. We consider that critical. The meetings were intermittent. I know I have not done a good job at getting the meetings out there. We are going to change that. And then we're posting applications that a number of the members are rotating out, and I think there's only 5 left. We're posting applications. We're going to get resumes. This week, we encourage people to send in resumes who are in all these different specialties. The number of specialties were not well represented on the committee, and we want to increase that to make sure that everybody is represented there. and to increase the number of meetings and also increase the transparency of the meetings.
In January of 2026, the addition of the American family physicians, a lot of physicians that practice all across the country read, they follow this. Dr. Doug Campos-Altkult raised some concerns about the future of the task force that we're talking about here. Particularly, he talked about the risk of undermining its independence and evidence-based methodology. And Mr. Chairman, I ask unanimous consent that this article I could submit to the record.
Without objection.
Thank you, Mr. Chairman. And I share his concerns because what we've just seen for the last year, the task force's methodology is grounded in an independent review of the evidence, careful evaluation of the benefits and the harms, and among so many health providers, it is widely been considered the gold standard for preventive care. So I hear what you're saying in terms of the different specialties and people rotating off.
I can promise you, Senator, we're not going to undermine any of those functions, and I don't think we'll get any criticism for doing so. We just want to get the best people and have a more representative group of specialties.
Okay, so you believe it's still the current methodology, the way they do it is still the gold
I think
standard?
there are some limitations that we are trying to address, and I'm happy to meet with you or consult with you to make sure we're doing it right.
Well, no, I'd be very happy about that. And then, you know, on vaccines, and a number of people have asked about vaccines. You committed when we visited in September to increasing transparency, to rebuild trust in the public health guidance. And since then, there have been some changes to the vaccination schedule, specifically with children. There have been some disruptions to the advisory committee on immunization practices. And I think that there's been more confusion for families and for providers, and I just think sometimes it's very hard to keep up with some of the recommendations. So I'll ask you again, are you taking steps now to ensure vaccine guidance is clear, evidence-based, and trustworthy, and what those steps would be?
Yeah, absolutely, that's what we're doing. For the first time, we're going to be doing, for new vaccines that are not yet on the schedule, to make sure that they have safety studies, placebo-controlled trials first. And for the vaccines on the schedule, they're being reviewed. There's a limitation. I can't really talk about it because it's under litigation.
Thank you. Thank you, Mr. Chairman.
Thank you. Senator Cassidy.
Oh.
Hey, Mr. Secretary, thanks for coming in. First, just a statement. CMS is working with Louisiana to approve Medicaid provider tax preprints after passing the Working Families Tax Cut Act. We have one more to be approved, the Physician 2026 preprint. Louisiana's fiscal year starts in 2 months, and we just need to get this done ASAP, as was congressional intent. Please prioritize getting it resolved, and I'll follow up with you and Dr. Oz, but critical to my state's providers and to my state's fiscal health, if you will, that this be complied with. So,
I'm happy to meet with you, or you know, I'm happy to put my staff in touch. You can call me anytime to make sure it's happening.
thank you, sir. Next, affordable health care. My gosh, when I'm on the campaign trail, for example, or just speaking to folks back home, it's all about that. We have expanded access to health savings account. Now, I'm not clear, though, particularly on the exchanges. So a bronze plan is now eligible for an HSA, as an example. How is the department alerting folks, enrollees, that this HSA opportunity exists?
I'm aware of the opportunity. I do not know whether there's an advertising campaign or what. I will check on that for you, Senator.
Thank you. The Biden administration...
I mean, the Trump administration is absolutely committed to increasing access to HSAs and to direct primary care and to the catastrophic plans. And so we, you know, we'll do everything in our power to make sure that that is known.
Sounds great.
An opportunity is known.
Staying on the exchanges, there was a lot of fraud with zero premium policies in the ACA. People paying hundreds of millions of dollars in fines for doing this. I'm not seeing additional funding to address that fraud in your 2027 budget. And yet I recently had an insurance broker told me she is still seeing folks fraudulently enrolled in the ACA marketplace. So the problem continues, even though there's now a greater awareness. Going back to your budget, there was not dollars that I saw to address ACA fraud. Any comment on that?
Well, the President's Marketplace Integrity Rule eliminates the zero premium plans. Those plans were particularly subject to fraud. We think there were 4.4 million people on them who, many of them who didn't even know they were registered because there was broker fraud. People were getting names, signing people up, and collecting the commission for signing people up who didn't know they were signed up. There were, I think, only 40% of the people on it ever made a claim, which indicates.
Except all that.
Yeah.
But it appears that the problem persists. And so I'm being told by folks involved, but the budget, as we see it, does not have money to go after that. How is knowing that we've already done good work, what are we doing prospectively to attempt to address the continued threat and perhaps reality of fraud in the marketplace?
I mean, we're using now AI throughout the department to detect fraud, and we're using it very aggressively. We have the best people in Silicon Valley who are now designing the systems.
Now, is that on the Medicare, Medicaid program?
For Medicaid, Medicare let out the door, but I think, we're relying on the Marketplace Integrity Rule to eliminate a lot of the opportunities for fraud in the ACA.
Okay, we may follow up with you on that just for clarity.
Okay.
Next, on Medicare Advantage, we know Medicare is going insolvent soon. We want to protect the 72-year-old retiree in Jefferson Parish, for example. Your department has banned the use of unlinked chart reviews, a little technical, but you and I know what we're talking about. But in the latest MA rate notice, HHS is continuing to use 2018 diagnoses and 2019 expenditure data, not 2023 diagnoses and 2024 expenditure data. Why would CMS not use the more recent numbers, which gives more precision as regards what the expenditure, what the payment should actually be?
Well, I can't answer that question. The guy who can is behind me, Chris Klump. But we're happy to talk to you about it. We know we went through a lot of effort to end the delinking of chart reviews with the with payments to end the upcoding fraud, which was the biggest opportunity for fraud throughout the system. So I don't know why we got the year, why we're not doing it, back to it, doing it to 2023 and 2024, but I will find out for you.
Sounds great. With that, I yield. Thank you, sir.
Thank you. Senator Johnson.
Thank you, Mr. Chairman. Mr. Secretary, welcome. Thanks for your service. Thanks for putting up with all this abuse. But in particular, thank you for your commitment to radical transparency. I think you're aware of the fact that I, on many fronts, think our response to the pandemic was a miserable failure. I'm also well aware that because the pandemic's over, so many people just want to put it behind us. Let's not examine all the things that went wrong. One group of people who do not want to move on, one group of people that insist on a reckoning, are those who were injured by the COVID mRNA injection. I think you're aware of the fact that on VAERS today, worldwide, we have almost 1.7 million reports of adverse events, almost 39,000 deaths. By the way, of those deaths, 24% occurred either on the day of injection or within 1 or 2 days. Now, I know VAERS doesn't prove causation, but man, that's a correlation. The injection injured, I refuse to call it a vaccine, it's not a traditional vaccine. The injection injured, at a minimum, would like to have their injuries acknowledged so they can get treatment. I saw a horribly sad video of a man in Japan, the central line, being effectively treated for his injection injury, couldn't get treatment here in the U.S. One of the things preventing is we have no ICD code for those. So I know this is running through HHS. I think NIHA Director Bhattacharya is looking for an ICD code. I'm just asking you if you're willing to look at that and prioritize that to get the injection injured at least an IDC code and acknowledge these injuries. Would you make that
We are
commitment?
working on it, and we are working on it. We're trying to make that happen as quickly as possible, and we're also doing the studies that now need to be done at NIH, the coroner's reports on the blood, clots and all of these.
I'm glad you talked about coroner. So my next question is a memo that is apparently leaked from CBER Director Dr. Prasad in December 2015, where apparently within FDA you're reviewing, I think it was 96 autopsies of child death following the COVID mRNA injection. In that memo, Dr. Prasad writes, "This is a profound revelation. For the first time, the U.S. FDA will acknowledge that COVID-19 vaccines killed American children. Healthy young children who faced tremendously low risk of death were coerced at the behest of the Biden administration via school and work mandates to receive a vaccine that could result in death. In many cases, such mandates were harmful. It is difficult to read cases where kids 7 to 16 may be dead as a result of COVID vaccines. Putting these facts together, it is horrifying to consider the U.S. vaccine regulation, including our actions, may have harmed more children than we saved. This requires humility and introspection. It requires oversight." And so I wrote a letter to you and your agency back on December 15th. Of the 10 responses, I got 3 out of 10. No responses, no response in terms of the documents I requested. So I'm asking you, please, will you commit to responding fully to my December oversight letter?
You have my 100% commitment.
In the letter, we also mentioned the fact that I was requesting the deliberative process on the Biden administration last minute requesting or granting a 4-year extension of the liability shield for these COVID injections. So please, would you also commit to providing me that those documents?
If we have them, I will hand them over to you.
Finally, let's just put up this graph. Because of your radical transparency, I've got close to 11 million pages. We uncovered they hid the signal on myocarditis. We also just recently uncovered that they also hid a signal on ischemic stroke for people over 65, the tail end 2022, 2023. They hid both signals. They downplayed them. But what is most alarming, and we'll be holding a hearing on this next week, I've got a draft report. They were made aware, Peter Marks was made aware on March 26th of 2021 that the inventors of the algorithm that analyzes the VAERS data was going to mask adverse events. He was told that by using a different system, they had uncovered 49 examples of extreme masking, 25 significant adverse events, including sudden cardiac death, Bell's palsy, pulmonary infarction. So this report will be issued in conjunction with that hearing. Again, I didn't need a sophisticated mathematical model to tell me that we had safety signals screaming at us. This chart shows the deaths associated with the vaccines all the way going back to 1990 when VAERS started, a couple hundred a year. Anaphylactic shock, that type of thing. 2021, over 20,000 deaths, and for 5 years, FDA has been saying, we don't see a signal. This was a signal screaming at us that to this very day, we are covering up. So there are a bunch of people involved in this cover-up that still continue to work within the HHS, CDC, FDA. I want your commitment that those people will be made available for interviews. I'll have to subpoena others. I'm going to dig into this massive government.
You have my commitment.
Thank you.
Thank you. Senator Smith.
Thank you, Mr. Chair. Mr. Chair, a few rounds ago, there was a back and forth between Senator Daines and Secretary Kennedy about mifepristone. So mifepristone's safety profile is well established, 25 years of data, 100 peer-reviewed studies. It's a safety profile that is better established than many everyday medications. And so I'd like to submit for the record, Mr. Chair, 40 peer-reviewed statistically significant studies on mifepristone's safety profile. These are the same that Senator Hassan submitted during Secretary Kennedy's confirmation hearings.
Mr. Chairman, just very quickly, I'd like to associate myself with your important remarks.
Without objection.
Thank you very much. Good morning, Mr. Kennedy. I'd like to talk about prevention and where we should be able to agree not only to how prevention can help to keep Americans healthier, but also save healthcare dollars. And I'd like to start by associating myself with Senator Barrasso's questions and concerns about what's happening with the Preventative Services Task Force. But let's get into it. Last week you said that screening for prevention is absolutely critical. So I want to dig into that. I agree with that. Let's start with mammograms. Would you agree that mammograms are important preventative healthcare?
Yes.
Absolutely. I agree with that too. So it makes me wonder why your agency cut the programs that fund breast cancer screenings. Hospitals in my neighboring states of South Dakota and North Dakota actually had to pause breast cancer screenings because your agency announced cuts to the National Breast and Cervical Cancer Early Detection programs. Doesn't make any sense to me. Let's try another one. Is depression screening preventative care in your mind?
And depression?
Yes.
Yes.
Yes, okay, I agree with that too. However, the Trump administration and congressional Republicans pushed through the biggest cuts to Medicaid in the history of that program, and Medicaid is the largest payer of behavioral health care. So that's cutting access to care for millions of Americans to get mental health care. How about smoking? Is smoking cessation, preventative care?
Yes.
Okay, so again, your latest budget eliminates the CDC's Office for Smoking on Smoking and Health, and 200 CDC employees who were working on smoking cessation are gone now. The flu shot, is the flu shot preventative care?
Yes.
Okay, so you said that it would be better if fewer kids got the flu shot. You've rescinded recommendations for scientifically and medically sound flu vaccines. You've canceled public awareness campaigns about the importance of getting the flu vaccine. I mean, this is not a record that matches with saying that preventative care is important. I do not understand the contrast here between what you say you want to do and what is actually happening in this administration. Now, let me go to this. Are you familiar with Title X?
Yes.
Okay, great. Title X is a highly successful, comprehensive strategy to provide birth control and preventative care to low-income women. And we know that every dollar that's invested in Title X, Mr. Chair, saves somewhere between $3 and $7 in Medicaid costs, preventing unintended pregnancies. So, Secretary Kennedy, can you explain why you were recommending zeroing out funding for Title X, which would eliminate screenings for cervical cancer and would almost certainly result in higher unintended pregnancies?
Can I respond to some of your earlier statements?
Please.
First of all, there are no cuts in Medicaid. I keep saying this. Here's what the CBO said. Fiscal year 2025, $668 billion. Fiscal year 2036, $981 billion. That's not
Secretary
a cut.
Kennedy,
It's a 47%
$1 trillion
increase.
in cuts, according to the
terms of-
CBO. 7 million people losing their health insurance because of the Trump administration actions. That's not debatable.
There's nobody who is legally enrolled in Medicaid who is losing
That is
coverage.
just not
Nobody.
true.
Nobody.
That is just not true.
It is so.
How else would you like to respond to my questions about why the administration is cutting preventative care?
We're putting, a lot of it is being returned to the states. We're doing a $667 billion block grant to the states for
My
mental health.
counties are asking why the cost shift to their taxpayers is happening at the same
It's the
time that
federal
rural
taxpayer. The
hospitals are
states
going out of business,
The
Secretary
states administer
Kennedy.
the programs better than we do. So we're giving the same money to the states to administer the program.
That is not the way it is working. Thank you, Mr. Chair.
Thank you. Senator Lujan.
Thank you, Mr. Chairman. Mr. Chairman, I'd like to ask unanimous consent to submit into the record a CBO report from July 2025 on HR 1. Unanimous consent to
Without
submit that
objection.
report. Appreciate that. Mr. Kennedy, that report found that there was a $990 billion cut to Medicaid, CBO report. That's not my
How
question.
can it be a cut?
Well, that's, Mr. Secretary, it's in the record. Be happy to share it with you. Your team has it as well, CBO report,
It's
July
a cut from the growth
2025.
rate. Only in Washington is that considered a cut.
There you go, Mr. Secretary. In the same way that gas prices are not high today.
It
So, all right.
doubled in the last 4 years.
Mr. Secretary, let's talk about vaccines. You've been asked quite a few questions today about vaccines. Your hearings this last week in the House as well, you've been asked a lot of questions about vaccines. You've been responding quite a bit about vaccines. I went back to look at statements you've made, I don't know, over the last 10 years or so on vaccines as well. I appreciate that you say today that you support people getting vaccine. Is that accurate?
Yes.
I was reminded, though, that, July 6, 2023, Samoa 2019, August 2018, February 23rd, 2021, and the dates go on, and I have a list of them, where there was a lot of misinformation predating
Tell me a
this.
piece of information that I ever promoted about vaccines. Tell me one piece of information.
Mr. Secretary, again, if I could continue.
Tell me
what-
one piece of misinformation. You said I've
Mr.
promoted
Chairman?
misinformation.
Thank you, Mr. Secretary. I'll get there. So, Mr. Secretary, the history shows that you were pushing vaccine misinformation predating your tenure.
Tell me
as
one instance.
Secretary.
Tell me one
I
statement
just
that I
shared with
made.
Mr. Secretary.
One statement.
So now, during your leadership at HHS, measles, a disease once eliminated in the United States, is on the rise in over 1,700 Americans, as you're aware. You've been asked by colleagues as well where, kids died last year as a result
Can I answer the
of dying from
question?
vaccine. I don't have a question yet, Mr.
Hey,
Secretary.
you're making misstatements.
At a previous hearing, you seemed to almost brag about how well the United States has fared in response to measles outbreaks compared to Mexico and Canada. I think here again today.
And Europe and all the other
The
countries.
United States has always been a leader, and we demand that it's a leader. That should not be a question.
We're still the leader.
Can you please tell us here today what you're going to do to reduce the number of measles cases and improve the MMR vaccination rate?
Improve the MMR. We promote the MMR. We advise every child to get the MMR. That's what we do.
Mr. Secretary, I'd be happy to just ask for that to be in the record, and I'd be happy to get a question in the record. You can respond to it.
Yeah.
I'm real curious if you're going to include funding a coordinated vaccine education and distribution campaign, for example, countering misinformation about measles and the MMR
Tell me
vaccine.
one piece of misinformation I've ever said. One statement, just one.
If I could continue, Mr.
You
Secretary.
say you have a list of them. Read one.
Tailoring outreach to communities with declining vaccination rates as well, measuring whether those campaigns are working.
You're
I
just
think
making
that-
things up, Senator. You're just inventing stuff. Tell me
Mr.
one
Secretary,
piece of
what
it. You
I'm
say you
asking-
have a whole list there. Read me one thing I've ever said. that
Mr.
is-
Secretary, if you want to run for the United States Senate and get on the dais here, you're happy to do it. You should resign from the HHS today and run for office. And you can be in here, you can ask anyone all the questions you want, Mr. Secretary. I'm asking you some questions. What I just gave you wasn't
You're
even.
not asking questions.
Mr.
You're just
Secretary-
making statements that are incorrect.
Let me ask you a question about someone that you know very well, David Geyer. So, Mr. Secretary, does David Geyer work for you?
He is a contract.
So,
he's a
Mr.
contract
Secretary,
employee.
last time you were here, I asked you, why was it that David Geyer was listed on the HHS director as a senior data analyst? He still is. Is he
He's
a
a
staff
contract
member or is he a
employee.
contractor?
He's a contract employee.
Mr. Secretary, you were asked by one of my colleagues about getting their hands on some documents that you may have. Do you have Mr. Geyer's contract?
I imagine we do.
Would you share that with the committee by Friday?
I don't think there's any legal problem with it. If I have
It's
to
not a
check
legal
with the
problem.
lawyer.
It's subject to Information and Public Records Act, which we could go about
Well,
as
then,
well.
yeah, I'm happy to.
I appreciate that.
If
And including in the contract, would you share, can we expect you to share with the committee by Friday the scope of David Geyer's contract?
I don't see any reason why not.
I appreciate that. Does David Geyer report to the HHS office here in DC?
He reports to CDC.
So what I asked for in the last time we had a conversation, Mr. Secretary, was about the protocols that go into David Geyer's work. You responded to me by saying that those protocols are public. They are not. I asked the committee chair.
I said
and
they
ranking
will be
member,
public when he does the work, when he develops the protocols.
will you commit to share the protocols to David Geyer's work with this committee by Friday?
No, I won't, because they
So-
don't exist.
Okay, so, Mr. Secretary, I appreciate that honest response. Mr. Chairman, Ranking Member Wyden, you'll remember, and I can get you the information from this. Last time I asked this question to the Secretary, he said it was all public, it was all available. He just said it's not. So I don't know if it's going to take a
I said it's
subpoena or an
going,
IPRA.
I said we will make it available when it's done.
I certainly hope that we can get our hands on the protocol information and David Geyer's work. Thank you, Mr. Chairman.
Thank you. Senator Blackburn.
Thank you, Mr. Chairman, and Mr. Secretary, thank you for being with us today. We appreciate it. I really want to applaud your leadership on the CMS strategy to crush fraud.
This is getting longer and longer.
This is something that Tennesseans are welcoming, seeing, and the fact that you have already found, I think it's $5.7 billion in fraudulent Medicare payments, and when you look at that as a recurring expense, you see how much that's costing the taxpayer. Pardon me. I also want to highlight the remarkable success we have seen with the Rural Healthcare Transformation Program, and Republicans on this committee really worked hard to make that happen. We're looking forward to good results. I do want to go to your question, your comments about fraud and fighting fraud. And you mentioned the work that was being done to beef up your systems. Pardon me. Too much pollen in the air. Talk for a minute about what you're doing there with the data transfer, with aggregating data from the states, and what you plan to do to make certain that the audit is now a mandatory component to weed out some of this fraud like we've seen in Minneapolis and in LA.
I mean, let me just talk about what happened in the Biden administration that opened the door to all this fraud. The Biden administration took many steps, but three major steps. One, it implemented what they call a pay-and-chase system, where when we get invoices that we know to be fraudulent, we have to pay them. And then they had a clawback strategy that then you would go after them, and of course, nothing ever got clawed back. And it opened the door wide. Two, they told the states that they could only check for enrollment validity once a year. They can find them. They told people in my agency, we had 80 people assigned to do program integrity and fraud detection over 50 states and 6 territories. It wasn't enough. The Biden administration came in and fired all but 6 of them. So now when I came in, I have 6 people in my office. My predecessor, Mr. Becerra, told his staff, we don't do program integrity, we should focus on enrollments. And that's what happens. And so now you've got all of these problems, and I'll give you one example. The hospices in Los Angeles. We've shut down 500 of them. We have not gotten one call from a congressperson or one call from a patient. Why? Because those hospices did not exist.
Right.
They were signing up patients. They were getting patient IDs, signing them up, and charging us $6,000 a month for that patient. How did we detect them all? Because the patients never died.
And then you are, I would assume that you all are sharing this information with the states and working with the states when it comes to Medicaid fraud.
Some of them refused to work with us.
Okay.
Minnesota refused to work. Florida, where there was terrible fraud in the durable medical equipment space,
Right.
is working very aggressively side by side with us, with the Governor DeSantis and with the Attorney General. Certain states have refused to produce an
Okay.
audit.
All
In
right,
those
I want
states, we
to-
are withholding their reimbursements.
I want to move to the area wage index. This is something Senator Warner and I are working on because you've got hospitals in urban areas and they are receiving higher payments than the hospitals in the rural or the low-wage communities. But of course, we know that so much healthcare now is technology, and technology costs the same regardless of where you are. And last week, I know that at the Ways and Means hearing, they discussed this issue with you, and I would like to know that you are confirming your support for the approach of bringing into parity this area wage index so that we can level the playing field with these rural and disadvantaged hospitals with hospitals in urban areas.
Yeah, absolutely. And I've worked on it with Senator Whitehouse because he has the same problem with Rhode Island. Unfortunately, there's no way that we can fix it in HHS. We need congressional help, and we will work with you on
Well, we have the bill and we are pushing it forward.
Yeah.
Thank you. Thank you, Mr. Chairman.
Thank you. Senator Young.
Welcome, Mr. Secretary. It's good to have you here. Thank you to you and your team for your hard work and for your focus on preventative measures. I think that point of emphasis of the Make America Healthy Again movement's important. Focusing more broadly on wellness as opposed to just healthcare and health delivery is important. I also appreciate the attention and interest you've shown in with respect to long COVID. This collection of symptoms that remain after people get COVID and has an economic cost globally of conservatively at $1 trillion per year. It's adversely impacting millions of Americans. No doubt is having some impact on our long-term unemployment rate, and people need some hope. And I think you offered some hope. For starters, during your confirmation hearings, when you told me you were going to prioritize this issue. Secondarily, when you held a roundtable session, bringing in some of our nationally renowned doctors who have expertise in this area. I'd like an update, sir. How are you working with your FDA Commissioner, McCary, and our NIH Director, Bhattacharya, to advance treatment for long COVID?
Yes, we are, Senator, and a lot of the reforms came out of that long table. That round table. I want to thank you for your leadership. And we're working with many of the doctors that we brought in, with Bruce Patterson from California, with Jordan Vaughn from Florida, and the leading doctors who become experts in this area, and we are working to develop biomarkers. As you know, there are many, many different presentations of this disease. They have to be identified and diagnosed differently. They have to be treated differently. We are identifying the biomarkers for those. We're putting everything up on a website so that patients will have access to the best care and the best doctors who have had the most success in treating their particular form of the illness.
Well, there's urgency to this. Thank you for prioritizing this. I will ask again for your commitment to continue to work together on this. Do I have it?
Oh, yes.
Okay. And I'll see Dr. Alicia Jackson later today. Of course, our director of ARPA-H. This seems to lend itself to the ARPA-H model in light of the fact that once we come up with treatments, diagnostics, et cetera, it typically takes 2 decades to find their way out in the clinical practice. We can't wait for that. So moving on to biotechnology more generally, for the last couple of years, I've chaired a National Security Commission on Emerging Biotechnology. Bottom line up front, we have assessed that unless we optimize our nation's biotech research, development, production, and innovation ecosystem, we are at risk of falling behind the Chinese Communist Party, our primary adversaries by my lights in biotechnology, which has direct national security, economic security implications. In 2022, Chinese pharmaceutical companies accounted for just 5% of licensing deals. By 2025, that figure jumped to 42%. I've been encouraged to see the FDA under your leadership speed up approval times for drugs, but I think more needs to be done. We outlined some of this in our report, which can be found at biotech.senate.gov. How, Mr. Secretary, can we work together to spur further domestic development and investment in the U.S. biotech industry?
Yeah, and last year, 50% of the new drugs approved came out of China, and that rate is increasing exponentially. And they're stealing our IP, they're stealing our researchers, they're stealing our best scientists. They're operating duplicate labs in other countries, and it's a crisis. They're threatening our biosecurity and our public health and our dominance in the area. As you pointed out, we have speeded the length of time from concept to commercialization dramatically. We just approved in record time 2 oncology drugs, one in 54 days, one in 45 days. The average for that part of the process was, before that, was 310 days.
Yes.
And both of those are drugs that bring people out of a hospice. Literally, they're so effective. We are now doing inspections in China, so we're dramatically ramping up our inspection of Chinese sites. A lot of them are violating ethics, the clinical trial sites. They're using minorities against their will and doing all these kind of mischief that needs to be exposed. We are investing hundreds of millions of dollars in reshoring KSMs and APIs in this country so that we can end that chain. And we have a pre-check program that encourages pharmaceutical companies to build in this country. The ones that produce the drugs here, if they research them here, they will be given preference and be able to move up in the line.
Thank you so much for your leadership as it relates to this issue, Mr. Chairman.
Thank you, Senator Tillis.
Thank you, Mr. Chairman. Secretary Kennedy, thank you for being here. You mentioned China. I was just chairing a committee for the last 2 hours on China's rampant theft of intellectual property and all the other malign activities they're involved in, which actually takes me back to a statement I think you made a while back about China is eating our lunch on pharmaceutical innovation. I think there's an argument to be made that we're handing China our lunch. I've talked about this in the committee for several years. By simultaneously cutting NIH funding for basic research and imposing MFN price controls that slash private R&D by 30 to 50%, HHS is squeezing both sides of a balloon and expecting it not to pop. And I'm not picking on this administration. It's exactly what the Biden administration did with the Build Back Better bill. Within 6 months of passing that bill, trying to impose price controls, we saw a 40 to 60% drop in small molecule research. It's inescapable, the connection between the two. So I think that these steps that this administration's taking, similar to the steps of the Biden administration, China gets the IP, China gets the manufacturing, America gets the lower prices on drugs we didn't invent, produced in facilities that we don't own, and you've already alluded to the unacceptable circumstances in China for the workers and those there. We're aiding and abetting that, I think, through this policy. So MFN tells the world that America will no longer invent in the future, in my opinion. Now I want to get to a question, give you a chance to answer that. For years, I've been saying that we've got to drive down healthcare prices. We've got to drive down the cost of pharmaceutical drugs. But we have a simplistic approach that we use here. We never have everybody in the barbershop at the same time. We just try to scalp whoever we can as a matter of public policy. MFN is the most recent example of that. MFN is the most aggressive single-link intervention in a complex value chain attempted at the federal level. It doesn't address supply chain concentration or IP theft. It just hammers the end price in hopes that the rest of the system magically adjusts. So well-intentioned, single-link interventions have failed for a decade. What, other than political branding, makes this one different? In other words, the Democrats had embraced this for years, this sort of socialized approach or socialized approach to controlling prices. What's different about now the Republican approach to do almost fundamentally the same thing?
Senator Tillis, when President Trump charged us with lowering prices to the same as Europe, he also made two separate provisos. He said he did not want to end the research domination of the U.S. companies, and he said he wanted them to reshore pharmaceuticals, which seemed like an impossible task. We managed to do all three things. And the truth of that, our success of that, is reflected in the share prices of those pharmaceutical companies that went up about $1.3 trillion after we signed the agreement. And the way the magic, part of the magic.
And are you certain that we will see an equal or greater amount of R&D coming out of these companies that have taken price cuts?
Well, yeah,
because we've seen the empirical data from Build Back Better, it didn't prove to be true.
Look at the investments they're making in our country. I think Eli Lilly's building 6 new plants, Pfizer's building plants, Merck is building plants, everybody is building plants here in this country. And
so why not, if the policy is working so well, why not apply MFN to everything versus the select number that you've chosen to negotiate agreements with, and I think have recommended that we codify those agreements?
We chose the top 17 companies that produce 99% of our drugs, our brand drugs. And we have agreements with.
But if it's working well, why not this just be a if it's working well and sustainable, why not this just be a universal program for any drug that makes it through FDA approval?
Each one of those companies had separate needs and separate circumstances, and there's separate agreements with each one of them. A lot of it, the magic behind it was that we used tariffs to force the Europeans
with that
to raise
in mind, how
prices.
could you possibly codify that if it represents different? I know that there's a discussion about codifying it. How do you codify something that is unique to each one of those entities?
Yeah, you know what? That is a long discussion, and I agree it's complicated, but I think that we can do it. The man who is the genius behind this is Chris Klump, and he's working on legislative language now, but you're happy. I mean, I'm happy to make him available to you.
Thank you. We'll submit other related questions for the record. Appreciate you being here today.
Thank you. Senator Whitehouse.
Thanks very much. Secretary Kennedy, I'm going to talk about some Rhode Island stuff with you. I think, as you know, and as CMS has long agreed, New England is a regional healthcare market, and there is literally zero justification for having Rhode Island suffer a 20% payment hole compared to its neighboring states of Connecticut and Massachusetts. You have said that that requires legislation to change, and that is what CMS constantly says. But as somebody who has tried to work this problem for well over a decade, what I have seen has been CMS has not even tried. They give no indication that they could care less about the disruption to healthcare services that this causes in Rhode Island. In the past, they have even gone out of their way to make the problem worse for Rhode Island, and I had to fight back and fix that worsening. But the underlying problem remains, and I just want to flag for you again that Rhode Island has been a leader in the move to value-based care. When accountable care organizations were set up, there were times when the two best in the country were Coastal Medical and primary care physicians of Rhode Island. So we've got a record of doing value-based care right. The move to value-based care could be the vehicle for correcting the payment hole. And I just want to flag that for you because I want to make darn sure we get there. We cannot be in a situation where Rhode Island's costs have been depressed because CMS kept Rhode Island's revenues down And now we're supposed to compare with Connecticut and Massachusetts, which had higher spend because they had higher revenues. It's obvious mathematics. I appreciate that you've taken an interest in this. I'm raising it again because I ain't going away on this subject. It is likely to cause real damage to healthcare services in Rhode Island if it is not fixed. The second irritation that I've had with CMS for a long time has been a similar disinterest with respect to how families with a loved one facing the end of their life get dealt with. It is not uncommon for someone to wish to die at home. It is not uncommon for the family to wish that they stay at home through this very delicate period. And yet there are times when the family just can't take it any longer and they're frightened and they would like to get their loved one to a nursing home. And what CMS has required is that that dying mom has to go and spend 3 days and 2 nights in a hospital, check in, go through all that rigmarole, all that nonsense, all that expense before Medicare would let them into a nursing home. We are fixing that with your help. I'm looking forward to getting that actually landed. But I just have to point out how long CMS was willing to stand idly by and look at that kind of effective cruelty in the system. Thank you for changing that. Similarly, if your loved one is dying at home and you want them to stay at home, you're not ready to go to a nursing home, but you need some help. Respite care for years was sending your loved one to the hospital. Again, all the anxiety, all the nervousness, the whole neighborhood worried about the ambulance in the yard, all of that completely unnecessary when you could send respite care to the home where the patient was less expensively. CMS was just obstinate about that. Ditto home care. If you're a dying patient, you still can get outside. You should still be able to get home care to support the family through that period. You shouldn't have to wait until you're homebound. So we're fixing those 3 things and others, but it's really important that we get this right. And I think Rhode Island, when we get this right, can provide a model for the rest of the country. And I just want to flag the vast bureaucratic disinterest of CMS over decades about these problems. And we just need to change the culture there so that they listen and think a little bit about the actual human harm that some of their policies are causing. Last thing I'll mention to you is prior authorizations. I'd love to get rid of even more of them. Prior authorizations make some sense in a fee-for-service model, but they've been abused by the insurance industry for cash flow advantage. In a value-based care model, the logical underpinnings for a prior authorization evaporate. So I would urge that you continue to work with us to get rid of prior authorizations for doctors who are working in a value-based care model. Thank you, Chairman.
Thank you.
Thank you for your leadership, Senator, and I agree with you.
Thank you. Senator Welch.
Thank you. My view, Mr. Secretary, is the healthcare system is absolutely broken. It's too expensive. And one of the areas that your administration is focused on, the president specifically, is the cost of pharmaceuticals, Trump RX. And I just want to go through that to determine what actually has happened. The front page of Trump RX says it has, quote, the world's lowest prices on prescription drugs. So I want to do a comparison about our prices versus prices, say, in Germany. And we have a chart here. This one drug, this is for infertility, $10 cheaper in Germany than here. Another one for diabetes and heart problems, $88 cheaper in Germany. Diabetes, $116. Another diabetes drug, $122. Autoimmune conditions, $1,653 cheaper in Germany. Another drug, really important for stunted growth in children, $2,723 cheaper. I mean, do you dispute any of these figures?
We currency and adjust the prices. So
You what?
we currency adjust the prices. So we're getting the lowest prices in the world.
So you're saying my chart is wrong?
Yeah, I'm saying it's apples and oranges, yeah.
I really don't get that. We check what the price is. I mean, it's $2,700 in apples more if you buy that autoimmune, that prescription drug here than there. I mean, the point here is Trump RX was sold as the cheapest prices. Our research shows it challenges that, unfortunately. Another thing, Trump RX isn't even the cheapest prices in the United States. Only a small fraction of available drugs are included. You know, there's 24,000 FDA-approved drugs. 80 drugs are on Trump RX, literally 80 drugs. And that obviously means that for the vast majority of drugs, they're not even in Trump RX. The other thing that is important is that the everyday Americans cannot access Trump RX. You've got a coupon if you go on the website, and it tells a very different story. A patient is not eligible if he or she is enrolled in any federal or state health care program with prescription drug coverage, such as Medicaid or Medicare, or any similar federal health program, TRICARE. Do you dispute that? This is the terms of Trump RX. The vast majority of people aren't even eligible. You know, the other point is that who's really benefiting? You know, you mentioned that there was $1.3 trillion in market increase for the drug companies. But I'm not seeing any reduction in cost to everyday Americans who want to get prescription drugs. You know, drug companies who made these deals were given exemption from Trump tariffs, right? They got a quid pro quo.
Only if they move their production to this country.
Well, so they got a tariff reduction.
They got a tariff reduction only if they produce here, and they get it for if they make a commitment to produce here, they can get it a year in advance.
All right, thank you for that clarification. But what I understand is that all but one of the 16 Trump RX companies have increased prescription drug prices since making their deals. The prices are going up. Companies that signed deals made even more money. You mentioned $1.3 trillion in market value increase, but those companies have made $177 billion in profits, up from $107 billion. You know, here's my concern. I met with President Trump in his first term. He said very directly, and he has on the campaign, that people are getting ripped off with pharma pricing. He gets it, but he's not solving it. Trump RX doesn't work. So I have a bill co-sponsored by Senator Hawley, the Fair Prescription Drug Prices for Americans Act, which would prohibit pharmaceutical companies from selling drugs in the United States at higher prices than at the international average, which is something I thought the president said he supported. Does your administration support that legislation?
Senator, we would love to work with you on the codification. You know, this does not, Trump RX does not yet cover every drug. It covers the most common drugs. It's dropped the price of GLPs by 89%.
Let's just level, though. It's 80 drugs out of 24,000.
It's the most common drug.
You can't be eligible if you're on any other health care.
It's the most commonly used drug.
The companies that have agreed to this have had increase in profits by $170 billion.
It's GLPs. It's all the most.
Trump RX is a fraud.
We need to move on. Senator Sanders.
Secretary Kennedy, how are you? You know, in public life, we all make misstatements, all right? A couple of hours ago, I think you said to Senator Wyden that we now pay the lowest prices in the world for prescription drugs. That is an absurd statement. Nobody in the world believes that. Do you want to correct that statement?
It's for the drugs that are on Trump RX.
I'm not talking about drugs. You said we pay the lowest prices in the world for prescription drugs.
Those drugs we do.
I'm sorry?
For those drugs, we do, Senator.
Well, for certain drugs, but in general, would you agree with the RAND Corporation and every other independent survey that we continue to pay the highest prices in the world? You agree with that?
Many drugs are not covered by the agreements yet.
On average, do we pay the highest prices in the world?
As we always have, except for
That's
the
right.
most common
I'm not
drugs.
saying this is a new development, but you said a moment ago that we pay the lowest prices in the world.
For the most common drugs, we do. Or GLPs, or IVF drugs, or COPD drugs, or asthma drugs, for insulin.
Well, let me give you an example. For the cancer drug Opdivo, it costs $260,000 in the United States, costs $56,000 in Japan. We paying the lowest prices, et cetera, et cetera. Senator Welch made the same point. All right, the bottom line is, look, there are thousands of drugs out there. There may be a drug here or a drug there. We pay lower prices. In general, according to the RAND Corporation, we now pay nearly 3 times as much for prescription drugs than 33 other countries in the OECD. You agree with that?
For the most common drugs, we have the lowest prices.
All right. I am working on legislation which is not inconsistent with what Trump has talked about, and that is we should not be paying higher prices for prescription drugs than people in Europe or in Canada. Is that a concept that you can support?
Yes, President Trump wants this codified, and you have a lot more power than we do.
You're right. You're exactly right, and that is why I am going to be offering an amendment to the budget process right now, which would in fact codify what Trump is talking about, that the United States should not be paying higher prices than other countries around the world. Is that an amendment that you can support and get Republicans to come on board?
We will work with you, but in theory, that's exactly what we want.
All right, let me ask you another question. We're on the Help Committee. Casey Means, who is the Trump nominee for Surgeon General, was before us a while back. She agreed with me that TV ads, prescription drug TV ads in America should be banned. As you may know, we're one of 2 countries in the world. Do you agree with that?
Yes, I agree with it in theory. Constitutionally, you can't ban it, but we are now regulating it for the first time, and you'll see that the ads have changed on TV recently because we've sent out 1,000 disciplinary letters.
You may be right, but I think, the people who determine the constitutionality of laws are the Supreme Court.
Well, we worked a lot on it because I wanted to regulate it.
Okay, but bottom line is, am I hearing you correctly to say that you would like to see a ban on prescription drug TV ads?
Yes.
Okay, good. There are a lot of seniors in this country who right now cannot afford dental care. Many seniors have no teeth in their mouths, can't afford hearing aids. I am introducing an amendment to the budget process which would expand Medicare to cover dental, hearing, and vision. Is that something you can support?
I'm happy to talk to you about it. I'm happy to work with you on it.
Other question. Right now, we have a diabetes epidemic in this country, an obesity epidemic. Many parents who would like to buy healthy food for their kids really can't make sense of the labeling on food products. All right? Other countries in the world are quite clear in their labeling about the amount of sugar, et cetera, that's in a product. Are you guys making any progress in coming up with simple, strong labeling on food products?
Yes, we are.
When will we see something?
Well, the delay in it has been that one of the big enemies, as you point out, obesity is costing 80% of Medicaid and Medicare dollars. One of the big problems is ultra-processed food, and there has been no federal definition or any usable definition. We've now worked out a definition. There are other, and here at HHS, we're in the process of going through the interagency process. There's other agencies that are Equity, USDA, Department of Commerce, OMB, and they are reviewing our regulations. As soon as we promulgate those, we already have the labeling ready to go.
Do you have any sense when that will be?
Excuse me?
Any sense when that you'll be promulgating that?
It has to go, Senator, through the other agencies that I don't have any control, but we want it to happen quickly.
Thank you.
Mr. Chairman, before he leaves, let me agree with Senator Sanders and ask unanimous consent that an article in the New York Times which shows that there's a higher price for Wegovy on Trump RX. This is the fact in terms of America, and Senator Sanders has been correct.
Without objection. Senator Warnock.
Thank you, Brother Chair. Secretary Kennedy, you're here today to defend the President's budget request. In September, you said that the CDC, quote, will again become the world authority on infectious disease policy. Do you still stand by that statement, yes or no?
We already are.
Secretary Kennedy, do you know what rabies is?
Rabies?
Yeah, do you know what it is?
is?
Okay, so rabies, people contract rabies, as we know, through bites from infected animals like skunks, foxes, like raccoons.
Yeah.
And it can devastate a family. When a pet is infected, it is very serious. It's 100% fatal in humans.
Yes.
If left untreated, and generally it's a horrific experience. Staff at the CDC Rabies Division in Atlanta, Georgia, have historically been able to field emergency calls 24/7 from providers about complex rabies cases using CDC expertise to determine appropriate care. Secretary Kennedy, since you and President Trump took office, do you know how many people are left to staff this 24/7 line?
I do not know, Senator.
Okay, so the answer is one. So I want you to know that there's one person left to staff a 24/7 line to respond to rabies, a disease which left untreated.
You know how many
is fatal.
rabies cases there are every year in the United States?
So I'm asking the questions. The CDC's infectious disease work has been so decimated under your leadership that there's only one person left to staff the line and respond to families about this very deadly and terrifying infectious disease. Let me ask about another disease. Secretary Kennedy, do you know what prion diseases are?
Yes, I do.
Okay, thanks. And when you think of prion diseases, one of them would be mad cow disease.
Mad cow disease.
And diseases like mad cow disease can be transmitted from animal meat to humans, and it can cause a rapid onset of dementia, challenges with walking, personality changes, and severe insomnia. It's also 100% fatal, and there is no cure, with people's brain tissue essentially turning into a sponge before death. Do you know which office at CDC monitors prion disease? So
I do not know, Senator.
It's the Prion and Public Health Office. Do you know what population is most at risk of contracting the disease?
I would say it's people who eat meat from CAFOs.
Yeah, so hunters. Prion and Public Health Office is critical in a state like Georgia. In Georgia, we have a lot of hunters. There are more than 600,000 hunters in my state, but your budget proposes to eliminate this office. Respectfully, you seem distracted, Brother Secretary. Why does your budget propose to eliminate the CDC office that focuses on monitoring this deadly infectious disease that's especially a risk to rural communities? Why are you proposing to eliminate the office?
There's a lot of cuts at the agency that nobody wants. We have a $39 trillion debt. We've been asked to cut across the agency 12%.
I assure you that the 600,000 hunters in Georgia would want this office. They would want the protection. I assure you that families that are dealing with rabies or the prospects of that would want to know that somebody's going to answer the phone when they call. You've come to Congress and justified destroying the CDC by saying you want to just restore the CDC's mission to focusing on infectious diseases. Yet you're also gutting the very offices that keep American families safe from disturbing and deadly infectious diseases.
Senator,
sir, hold on, sir.
Senator, there's 1 to 3 rabies cases a year in the United States. I think one person manning that office full-time probably can handle that traffic. In terms of prion disease, it's very, very rare.
I beg to differ. Here is the issue, and we see this across the board with CDC. The incredible folks at the CDC in Atlanta, Georgia, they protect us every day from the threats that we don't see. And they don't get much credit for it because of the stuff that does not happen. And it's okay for the general public not to wake up thinking about that. But we expect you to keep Americans alive. And the cutting that we're seeing, these draconian cuts, for an agency that you said you wanted to restore to be the leader in infectious disease, yet you're cutting the coverage of infectious disease. Personally, sir, even as you seem distracted while I talk to you about deadly diseases, I think you're dangerous to the American public, and you ought to be fired. And if you're not fired, you ought to have the decency to resign. You're way above, way in over your head. Thank you.
Senator Marshall.
Thanks, Mr. Chairman, and welcome, Secretary Kennedy. Mr. Chairman, it breaks my heart. I want to cry when I see the weaponization of health care used by my colleagues across the aisle. I've never seen so many disingenuous statements, misleading statements, the outright manipulation of data to meet their political narrative. I've never seen this before. And again, at stake is people's health, Mr. Secretary. Measles. 2/3 of the people that had measles last year were over the age of 5. Were you Secretary of HHS for people that are over the age of 5 that decided not to get a vaccine years ago?
That decision by those people predated my appointment, and I think it's 80% or over 5. And the epidemic, the outbreak started before I came into office.
Yeah, so thank you for helping clean up that mess. And I think about the flu vaccine, again, the total mismanipulation of data. Probably the biggest challenge with flu vaccines is it's not very efficacious. And I don't know whether it's 20 or 40% good, you get a shot. There's so many different brands and flavors of flu. Are you working on trying to make a more efficacious flu vaccination?
Yes, we are. We're trying to make a universal flu vaccine that can protect against all strains of flu. Many years, the vaccine is 20% effective or in that range. So we need something that actually works and that doesn't have to be given every year.
Yeah, and I'm so glad, though, today that my colleagues across the aisle recognize the failure of Obamacare. Pointed out both sides here, hundreds of hospitals closing, but there's no policies that this Congress has passed that are implemented yet. Our Medicaid policies, which will increase spending by 50% over the next 5 years or so, have not even taken effect till 2027 for the most part. So I think it's an admission that the ACA didn't work, that Medicaid expansion didn't work. Why do we have failing hospitals now? Well, number one is overregulation, especially in smaller hospitals. The ACA led to so much overregulation, which leads to consolidation of industry. The next issue is the depopulation of rural America. We built hospitals with 50, 100 beds, and now the average census in these rural critical access hospitals is 1.6 patients per night. So it's just really hard to make a business plan that works like that. But I want to point out and say thanks to President Trump that our Medicaid provider tax, because that Medicaid provider tax, Kansas is going to get an extra $1 billion this year, an extra billion with the B dollars. Rural Health Transformation Fund, $222 million. Doc pay is increased by 2.5% as well. So I think that you have done some great things. I would assume that you've done as much financially for rural hospitals as any president in American history, any HHS has done.
I would agree with that. I think the Rural Health Transformation Fund is an inflection of money that increases the annual federal dollars to rural hospitals by 50% for the next 5 years.
Yeah, I mean, significant funding out of that $1 billion I was talking about from the Medicaid provider tax, increased new dollars to Kansas, of course, will be going to the critical access hospitals, making them eligible for it as well. And I want to talk about the rural emergency hospital model for a second. This is something that we worked on really hard in Kansas, saying, what is the alternative? Here's 3 hospitals in the same county. 2 hospitals, same county, 3 or 4 hospitals within a 20-mile radius. They're each seeing 1.6 inpatients per day. There's just no model that works. So what does work? What type of healthcare model works in rural America? What's really important to our rural American healthcare? Well, it's access to primary care, addressing our chronic diseases, but a darn good emergency room connected with telemedicine to a tertiary care center. That's what's important. And Mr. Secretary, I want to submit for the record some suggestions that would make it easier for hospitals to make those transitions to a rural emergency hospital model. And there's some that you can do, but there's also things that, guess what, Congress needs to do. Can you just briefly speak about rural emergency hospitals for a second?
Yeah,
I need to submit this for the record, please.
Without objection, and please be brief in your response, Mr. Secretary.
I think you're right. If you can't, if there's 1 or 2 patients a day, you can't sustain that are going to stay overnight. But what those hospitals do need is really top-rate emergency care. And as you say, you can now use telehealth to talk to specialists at a centralized hospital who can make sure that you're getting the best procedures possible.
Thank you, Mr. Chairman.
Thank you. And that concludes the senator's questions, except Senator Wyden has asked to make one more brief question, and then we will wrap it up.
Yeah, I saw in the news a little bit ago, Secretary Kennedy, that a 3-year-old girl was sexually abused in a foster home at an agency that you oversee. Are you familiar with this?
No, I am not.
You're the Secretary of Health and Human Services, and it's in a national publication, and you didn't know that a 3-year-old girl was being sexually abused on your watch?
I can tell you there were tens of thousands of girls and boys who were sexually abused. The Biden administration lost 425,000 children, and you never complained.
Whose job is it to inform you of something like this? Because this, to me, is an unconscionable case.
Yeah, but why weren't you worried when he lost 425,000 children? Why are you suddenly worried?
I read this in the
Why are
newspaper.
you suddenly worried about sexual abuse of children now and trafficking when it was mass promoted under the Biden administration, where they gave 425,000 children to adults without identification?
I'm asking the questions here, and this was in a national publication seen by millions of people, an unconscionable example of mistreatment of a 3-year-old, and you don't know anything about it.
This is selective indignation.
I'm just going to say.
It's very dishonest, Senator.
We have been working on this for years.
Why don't you help us find those children who are lost, still lost? We found 138,000.
We're working on this right now, and we'll have additional opportunities to talk to you. The reality is that this has been a long hearing, but a particularly important one, because the view on so many of these issues where you basically bob, weave, and deny, for example, your views on vaccines are toxic. You know, people are suffering as a result of your discouraging vaccination, and American families suffer. And I've asked you repeatedly to give specifics. We had all these members who are on our legislation, All these members say that they're concerned about Trump RX and people not getting fair prices. You could settle this by giving me tomorrow all the details. Now, if you want to talk about redactions or things like that, you can do it, but hand it over now so we can get going. And I think
Why don't you do an agreement yourself? You've had power to do that for 20 years and haven't done it, and that's why I was forced to do it.
For years, I pushed
Why are you
Big
complaining
Pharma.
about what I did instead of doing it yourself?
I'm speaking out today
It's
because
ridiculous.
I think this is a sweetheart deal for Big Pharma, and the last exchange proves it. When you kept saying the drugs were cheaper,
It is
result of this,
selective
and
indignation, Senator. It's all tribalism that's just destroying our country.
It's about public service. And
It's not honest. It is not honest.
I yield the floor.
Thank you, Senator Wyden, and Mr. Secretary, thank you for coming. You've spent nearly 3 hours here with us, and we appreciate you coming to have this discussion with us. Obviously, we have disagreements up here on the dais, and I think that you have handled yourself very well and you've answered the questions very well. I also think you're doing an outstanding job as the Secretary of Health and Human Services, and I commend you for the results that we are seeing, as I said in my opening remarks. Before we conclude, I ask unanimous consent that Senator Grassley's questions be entered into the record. Without objection, be so ordered. Again, Mr. Secretary, thank you for coming before the committee today. Members are informed that the questions for the record should be submitted by next Wednesday, April 29th at 5 p.m. And before I adjourn the committee, I would like to ask the public to remain seated while the Secretary departs. And with that, the committee is adjourned.